Welcome, everyone, and thank you for joining today's webinar. This webinar is hosted by the Mortality Estimation Initiative, led by Save the Children in partnership with Evidence for Change and Impact Initiatives. The initiative is co-funded by ECHO. We encourage participants to submit questions throughout the webinar using the Q&A feature. Live interpretation is available in French and Arabic. If you need interpretation, click More, Language of Speech, and Language Interpretation. Choose your language and adjust the volume to your preference. Today's recording and presentation materials will be shared after the webinar. It is now my pleasure to hand over to Sarah Ashraf, Lead Advisor of Global Health for Save the Children, who will be facilitating the session. Thank you.
Hello, everyone. Welcome to our webinar today. So today's webinar is Methods for Measuring Mortality in Humanitarian Settings, Survey, Surveillance, and Beyond. It's building upon the previous session that we had on mortality estimation principles and concepts. So as we all know, that reliable mortality data is essential for understanding the impact of humanitarian crisis, guiding response priorities, and informing evidence-based decision-making. In this session, we will move from theory to practice by exploring the main methods used to measure mortality in humanitarian settings, including their strengths, their limitations, the common sources of bias. So this will include mortality surveys and surveillance systems, their limitations, strengths, and sources of bias. It will also include census and registration approaches, verbal autopsy, and cause of death methods. We are very lucky to have two panelists today, two speakers, who will take us through this learning for this webinar. Our first speaker is Professor Les Roberts. So Les Roberts is a professor emeritus at the Columbia University, and he has taken part in the field measurement of mortality in crises, many of them, including Rwanda in 1994, more than 30 health zones in the Democratic Republic of Congo from 1999 to 2002, in Iraq, 2004, Zimbabwe, 2007, the Central African Republic, 2009, 2018, and 2022, and in Sierra Leone, 2000 and 2014. I have had the opportunity and pleasure to meet with Professor Les Roberts at one time, and I can assure you that his experience is amazing, and the stories and his learning is really very, very captivating. So I'm sure that you will have quite a few questions to ask him. Our second speaker for today is Daniel Cobas-Munoz is a physician and a global health systems researcher at the Swiss Tropical and Public Health Institute. He specializes in mortality information systems, verbal autopsy, cause of death analysis, and civil registration and vital statistics. He heads the WHO Collaborating Center for Verbal Autopsy at the Swiss TPH, and is a member of the WHO Reference Group on Verbal Autopsy and the WHO Reference Group on Health Statistics. His work focuses on strengthening the quality, integration, and use of mortality data to support public health decision-making, particularly in low and middle-income countries. We are very, very lucky to have both our speakers today, and we'll be learning a lot. So I will now hand over to Professor Les Roberts for the first presentation.
Thank you, Sarah, for your extremely kind introduction. So what she didn't mention is that when I have students for a whole semester, I can't teach them how to do surveys really well. So I've only got 20 minutes. I'm really going to focus on the advantages and disadvantages of surveillance and surveys. Next, please. So you probably know this, but I need to say it. Surveillance is the systematic and ongoing collection of information to achieve some goals. There are so many ways. The stock market indices, the unemployment rate in your country are collected systematically, creating a surveillance system. For mortality, it is also done in a lot of different ways. Counting graves that are created in a common graveyard or a common place where people bury their dead. Going monthly in Afghanistan to speak to imams in villages who know more or less about every death that happens there. Those are forms of surveillance, but the most common we have are systems by which either the medical system or the social system tries to record births and deaths. Next, please. There are huge upsides to surveillance. It's collected in real time. And we'll talk about what exactly that means. So when a problem arises, you learn about it as it's happening, unlike a survey that's telling you about what happened in the past. It tends to be collected over long periods of time, which allows you to learn things that you wouldn't have otherwise. For mortality, for health information, it tends to be collected through the medical system. And so you can have laboratory confirmation that that death really was an Ebola case, or you can have the highest quality medical assessment in a community making a judgment about what the cause of death was. So it tends to have higher quality assurance than other methods. And most importantly for you, it tends to be believed, especially by people in the government where you're working. Next, please. So here is some data that was collected when I worked for the International Rescue Committee, and it's showing the births in Metendeli camp full of Burundian refugees in Tanzania. And there are two really quirky things when I look at this 4 years of birth data. Notice at the bottom, low birth weight events, that is, a child born at less than 2,500 grams, are in light blue, and in red are essentially more than 2,500 grams or a normal birth weight. And you will notice that A, there's a dip right at the end of 1998, and B, you will notice that in the beginning, the fraction of births that are low birth weight events is much, much higher. Next, please. So this NGO collected this data every month, gave it to the local government, but they had never put it out in one series like this. And it turns out that in the region of Burundi, Tanzania, Rwanda, there was just an amazing spike of malaria in April of 1998. And you'll see that here, a third of this camp's population, which was 20-something thousand, was diagnosed with a laboratory test and treated for malaria. Next, please. So it shouldn't surprise us that 5 months later, there's a huge dip in birth because malaria in pregnant women very commonly causes them to lose their pregnancy. But what's more important, and IRC did not know this, and the World Food Program did not know this, is that they started giving a food supplement to pregnant women in the middle of 1998. And lo and behold, starting just 4 or 5 months later, low birth weight events went way, way, way down in this population. But what's more amazing is that there had been for years this chronic problem of syphilis-positive births in this camp. Women who essentially didn't go for antenatal care. And for those who don't know, when a woman is syphilis positive when she's pregnant, there are all kinds of horrible things that can happen. That she can lose the pregnancy, the birth could be low birth weight, the child can be born blind or lose its hearing. There's just a whole bunch of terrible complications. And who could have ever known that after years of struggling, the best way to control syphilis in syphilis positive births in this camp was to provide food to pregnant women. And thus, pregnant women had a much higher incentive to do antenatal care, and antenatal attendance went way, way up. Wow. Ongoing, systematic over long periods of time allows us to learn lessons like that. Next, please. So there was an outbreak in the city of Dushanbe in 1998. The Red Cross had this great, I'm sorry, 1997, had this amazing woman who tried to get the community to reduce their water wastage because the outbreak was caused by low water pressure in the pipes and really terrible leaks allowing sewage to leak in. And at the start of this outbreak, people were wasting more than 1,000 liters per person per day. And we did surveys sequentially over time and measured by going into houses picked at random and measuring the amount of water running through that toilet that wouldn't stop running and measuring the water leaking out of pipes. We measured how this community cut its water wastage in half over the year that followed. So here, sequential surveys are acting as a form of surveillance. And this happens with malnutrition a lot. Next, please. So there are some negatives about surveillance as well. They're subject to changing behaviors. If things change, you might get a change in your data without truly a change in the health situation. Very rarely does surveillance represent all of the population. And if there's some sort of stigma or fear about showing up to an Ebola treatment center or about admitting that my child has dysentery because it means they have a curse on them, well, then you might get poor data. Surveillance data in terms of mortality is almost never complete. Next, please. So here we are, we're back in Metindeli camp. And you'll notice that in terms of dysentery cases over those same 4 years, there's this amazing drop starting in the year 2000. You would think, oh, they started giving everyone latrines or doing something more hygienic. No, 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 no. In the first 2 years, it was an Italian doctor in charge of the medical services. And then in the beginning of 2000, there was this West African doctor took over, and he said, wait. 2 deaths per thousand, 2 cases per thousand per month. That's like the worst dysentery outbreak anywhere in Africa for 2 years continuously. I don't believe it. I want you, when someone comes in and says they have dysentery, to make them an inpatient until they produce a bloody stool. I want to see it. It turns out that if you went in and said you had diarrhea, you got ORS. If you went in and said you got diarrhea with blood in it, you got ORS and a really good antibiotic, in this case, nalidixic acid, which people could sell or use. So people had every incentive to say they had diarrhea, dysentery, when they had diarrhea. And here this doctor essentially eliminated dysentery by changing the definition. Next, please. Here is a clinic in the Republic of Congo, Congo-Brazzaville, and we saw this again and again and again, that when the Red Cross would make a drug delivery, clinic attendance would go way up. And then as the drugs ran out in the months that followed, the word would get out and attendance would just go down, down, down. And then 5 or 6 months later, the Red Cross would come again. They'd have a drug allocation. And we collected this data to show the donor how really important more frequent and complete drug deliveries were. So here is surveillance data allowing us to convince our donor to fix a problem. Next, please. I had a friend named Brent Burkholder. 3 Rohingya crises ago, he went to Cox's Bazar, and when he got there, at the burial sites, they kept records of all the deaths that were buried. There were way more girls being buried than boys. Next, please. And so he went to the clinic nearby. This is slightly different dates, but there were more boys being taken to clinics than girls. So he did some sort of exploration with key informants, had a couple focus groups, and it was abundantly clear that this population valued boys more than girls, and you had to pay a $1 fee to take your child to this MSF clinic. And MSF was mad as hell about this, of course. So the UNHCR took this data, went to the Ministry of Health, who was being forced to do this by the World Bank, and said, hey, come on, can we do away with the fee? And they did. Within 2 weeks, the differential in boy and girl death rates disappeared. Wow. Surveillance data allows you to fix a problem when it arises. How cool. Next, please. Surveys are this cross-sectional process of collecting data with some intention from a specific population at a specific point in time. Next, please. So because you're doing this at a moment in time, we're collecting, and mortality is something we want as a rate. In terms of declaring famine or telling the world how bad northern Mali is, you need to be sharing it as a mortality rate so people can compare it with other places. And that requires knowing deaths over a period of time with some denominator. Therefore, you're almost always collecting this data retrospectively, that is back in time. And you're asking about deaths from a really specific period, normally beginning with a really well-known date, Ramadan, New Year, Christmas, when the president was elected, when the earthquake happened, something that everyone knows. And normally it's ending with the day of the interview. If the recall period is too short, you don't collect much mortality data, so that's a problem. If it's too long, then people won't answer well. In both Libya and in DRC, great studies have shown if you ask women about the last 5 years of births they've had, they will underreport most infant deaths. So generally, people tend to default to having a 1-year recall, especially since if there's a seasonality in mortality where you are, then that's considered or taken care of. Next, please. So there's sort of 3 ways of sampling: systematically going over some discrete place, well, in a place like a camp, randomly selecting households or people so that everyone has an equal chance. That's probably the most common thing that's done. And because it takes so long to find a random starting point, normally you interview a whole bunch of houses, like a whole cluster at once. And there are times when you want to sample everyone. And a census is the word of essentially sampling everyone with regard to something. It works well in small camps and really discrete populations, not so well in most of our rural emergency settings. Next, please. So surveys have some advantages. They tend to be more complete. If you interview really, really well and there's no stigma and people are willing to talk, you'll get a better estimate than most surveillance estimates. You can control what information is collected. So if you want to know, do people have a high school education? Are people having trouble paying for clinic fees? If you want to know something else, you can include it. If you've made it so that everyone has an equal chance of being selected and interviewed, well, then you can do statistical testing at the end and find out, wow, is that higher death rate in women statistically different than the death rate in men? Or whatever it is you might want to test. And if you interview well and are listening well, sometimes you can learn very unexpected things. And I'll give you an example of that. There are disadvantages to surveys as well. If you knock on a whole bunch of doors and at least 2% of households don't tell you whatever it is you're looking for, surveys tend to not have enough statistical power to be meaningful. It takes a lot of skill, both in terms of communicating with people and understanding when they're scared or when they're lying, and also sort of epidemiologically and analyzing the data in a way that your critics will not be able to sort of tear you apart for. And finally, there's this tendency that if people don't like the results of surveys, they can just dismiss them if they have a different view. Next, please. So one of the first times in a humanitarian setting this was done was when a huge hurricane hit eastern Pakistan, which is now Bangladesh. And this group from Johns Hopkins could only get to like a dozen communities, but they sampled within those dozen communities, 3,400 households, and they found that almost 250,000 people had died. Interestingly, 21 years later, a virtually identical storm came, it followed almost exactly the same path, but the population had doubled. And the CDC did a mortality survey showing a 90% reduction in deaths. And they found that the predictor of surviving was getting to one of these hurricane shelters, that this was the protective thing that happened in these communities. And this triggered a massive building of hurricane shelters all across the Pacific Basin. Wow, what a spectacularly influential couple of surveys. Next, please. Likewise, there were a couple of women did a series of surveys in Mozambique in the 1990s. And interestingly, if a child had an attended birth, they were way more likely to survive at ages 3 and 4 than a child who was born without a medically trained person attending. And this was not explained by proximity to healthcare facilities. And the interviewers believed that it was the act of having an attended birth changed the family's attitude about health. And as a result, the family was way more likely to bring their child for healthcare when they had fever or other problems. This series of studies led to a massive movement starting in the 1990s about safe birthing. Next, please. Next, please. So I worked for the International Rescue for a few years, mostly in Congo, and we did some mortality surveys. It triggered a whole host, a dramatic increase in funding in Eastern Congo. We got healthcare service funding for a couple of health zones. There's 2 of them shown here on the top right. And we had measured mortality before. We got our funding at the beginning of 2001. And lo and behold, mortality went down in our health zones by a lot, and clinic attendance went up by a lot. And the bottom little graphic there is the city of Kisangani, which is right across the river from Lubinga, where we were providing health services for free. And there and in all of South Kivu, where the top graphic was, mortality actually went up from 2001 to 2002. And we estimated that we averted a death for every $300 spent. I can't articulate to you how ecstatic our donor was to have that information, to show how cost effective their spending was. Next, please. We're sort of out of time, so let's skip this and next, please. So there was a mortality survey done by this guy, Gang Karume, in CAR. It was sort of a standard survey. They broke the population into the government and non-government controlled areas. They picked 40 clusters at random, did clusters of 10 houses each. They asked a whole bunch of questions about births and deaths and pregnancies and if anyone had moved in and out. And at the end, they had an open-ended question. And next, please. In the end, they found that the official death rate was 4 times higher than the official UN statistics. And it was higher in the non-government controlled areas. The qualitative data suggested that this was triggered by the insecurity induced by the Wagner mercenaries who were there. And disturbingly, this had none of the expected effects. RHA's goal, Gang Karume's goal, was to increase medical spending and food provision by the aid community. But in fact, the next year, because of the crises in Gaza and in Ukraine, funding declined in CAR in spite of this mortality survey. Next, please. But interestingly, there was a presentation by one of the team that the head of the UN Statistics Office listened to. And he was really blown away by this. He didn't believe it was 4 times higher than their official statistics. He called up one of the investigators, grilled them for like 80 minutes. He then did the same thing with a guy in the London School of Hygiene about his study in South Sudan and in Somalia. And to make a long story short, this guy was so influenced by that study that in 2024, for the first time, the United Nations started to use statistics that did not come from either the UN or a country government in estimating mortality. And so for Somalia, Sudan, and CAR, the UN statistics got way, way, way better. How cool and how unexpected. Next, please. So to close out, census and vital registration, they're the gold standard, but sometimes they just don't apply in emergencies. Surveys and surveillance each have advantages. Surveys tend to be more representative and allow you to get sort of different kinds of information and generally a more accurate measure of the rate, but it takes skills and it can be disbelieved. Surveillance tends to allow you to detect things when they're really happening and stop them when they're happening, but it's almost always an underestimate of the true rate. For your information, I have a couple of manuals here on how to do each of those for your use later. Next, please. So thanks a lot. And we're going to take questions only at the end, and we'll go to Daniel now. Thank you again for having me.
Hi, everyone. So I'm Daniel. I'm part of the Swiss Tropical and Public Health Institute. And I think I have the feeling that I'm going to go just to the other side, to the non-sexy part of surveillance, talking about maybe not so much about civil registration and vital statistics systems, but with a focus on deaths and causes of death. If you go to the next, please. So just as a disclaimer, many things that I'm going to present here, they are not only my work, it's a work of a big team that is working at Swiss TPH, plus many other people in countries that we work with. So it's a collaborative approach. So it's not, I'm just the spokesperson. If you go to the next, and to the next, please. So in principle, so what we work a lot, I work a lot on mortality information systems, and everyone said, oh, they should be easy. So we know when someone dies, and it should be easy to document and record, but the reality is that it's not. So we are missing most deaths in the world. 1 in 3 are not being captured. The cause of death is much worse. So it's easy to recognize, but the problem is documenting it and documenting it properly. If you go to the next. Yes, so basically what we are trying to understand with mortality data is how many people die, where and when, and what is the cause. And I find useful, if you click next, I find useful to differentiate between the fact of death, that the fact that someone has died, you are alive, and the next second you are dead, and then the cause of death, because they are dealt with very differently, administratively, but also in the way we calculate them. If we look at just the fact of death, and I'm not gonna go in detail into this because Les has covered most of it. If you go next, please. And next, you can have this really nice graph. This is from Euromomo. This is just the number of deaths, not even by age and sex, over time. I think this is all European countries reporting to Euromomo. And you can see the trends, you can see the spikes of COVID, you can see many, many things only just by plotting number of deaths over time. So it's really useful, but I'm gonna focus, if you click next, and next. I'm gonna focus a bit on the cause of death. So what is the cause of death that we are interested in? So what we are interested in is in the cause of death that trigger the chain of events that led to death. So there are many causes of death. Is what is killing the patient now, what was intermediate between the underlying, that is what we are interested in, and the immediate. And for doctors, usually are doctors the ones certifying, they need to understand this sequence of causes of death that build the chain. So if you go to the next. And this is the situation in the world, how cause of death is being reported. So you see that, and I'm a doctor myself, doctors are usually not very good at recording the cause of death. If you go to the next, but when we look at the quality of the cause of death, we are also not very good either. So the problem is that doctors are trained to identify the immediate cause of death. We are trained for 6-7 years to identify what is killing my patient now. But we are not so well trained to identify, okay, what is the original cause of death that triggered the chain of events that ended up with this patient dying? What are the things that we can prevent? How can I prevent this death? We need to go to this underlying cause of death. If you go to the next, and next. So the way we document the cause of death the gold standard is the medical certification of cause of death. There is a standard form from WHO, and is the way doctors or some countries, they allow other clinicians, not medical doctors, to complete the medical certificate of cause of death. But in principle, it's a doctor that says, look, this person died because of this immediate cause of death that was due to this cause that originated in this underlying cause of death. And that sequence is essential, because then this is what helps us link the cause of death, the underlying cause of death, with the ICD code, the International Classification of Disease code. So that if we don't use this sequence, then it's not very useful. So if a doctor says this patient died due to sepsis, that's not useful, because sepsis could be the consequence of a respiratory infection, could be the consequence of an injury that got infected and then ended up in a sepsis. So sepsis is not very useful to design interventions. Sepsis is useful for medical practice, but not for identifying causes of death. If you go to the next. So then this is an example of a medical certificate of cause of death. So imagine that someone was hit by a truck, was taken to the hospital. He had or she had some fractures, and then in some hours he or she had a traumatic shock, and then he or she died. So this is the sequence that we want to see. We want to, if you click next. So what we are looking for is the pedestrian hit by a truck. That's what we call the underlying cause of death. This is the cause of death that we want to prevent. Then this pedestrian being hit by a truck had the consequences of multiple fractures that continued into a traumatic shock that then made the patient die. And then we also have the times there. So this is the standard way we document causes of death, and the way in which we can build cause of death statistics with the proper standards, with the proper quality. And this is usually done in routine systems based on the health sector to report this information to the next level. That sometimes is the civil registration office that captured all of this into the death certificate, or is directly to the National Statistics Office that then build the cause of death statistics. If you go to the next. And then once we have that information, we have these medical certificates of cause of death filled by doctors, then we go to the coding. We take the International Classification of Disease, the 10th edition, or if you click next, the 11th edition, we will have an ICD code linked to that underlying cause of death. So in this case, it could be the V01 in ICD-10, or it could be another code in ICD-11. But that's the whole machinery to build good quality cause of death statistics. And this is what is done usually in routine practice. I understand that in humanitarian settings, it's a bit more difficult to get through this process. But wherever there are hospitals, wherever there are doctors, this process can be included. If you click next. But then the reality in most parts of the world is this one, is that most deaths are invisible for the health system. Most people do not get to a health facility. Most people do not get to see a doctor when they die. So for most people in the world, that process is not responding. So it's not there. So then what do we do? If you go to the next. In those situations, we have a method that is called verbal autopsy. There are other methods as well, but this is kind of the more mainstream, let's say, for identifying cause of death in areas where you don't have a doctor. A verbal autopsy was developed around the 70s, and it has been evolving over time. And now there is a very robust methodology where basically you go to the family or to the next of kin or whoever was looking after this patient, and you ask them, okay, before dying, did he or she have cough? Did he or she have fever? So it's a structured questionnaire with questions and potential answers. And then there is a block for allowing the family to explain in their own words what happened. So this is basically a verbal autopsy. So it's a questionnaire. If you go to the next. And okay, I will come to this later. And it's being used in many different countries with different purposes, some of them humanitarian settings, some of them stable settings, to estimate cause of death statistics at the national level, doing it in surveillance sites, in health and demographic surveillance sites that do routine surveillance for decades. So it has been used in many different ways. So far has been used a lot in research settings, but now we are bringing it to routine information systems. If you click next, we go to the next. And whoa, okay, I don't know what happened here, but anyway, but you see, like, there are three main blocks. So we have the questionnaire, that is what I described. So you go to the family, you have a structured questionnaire with a narrative, you can record it, you do that. Then you need an analytical tool, and we will come to that later. And then at the end, you have what is called cause-specific mortality fractions, because we usually don't have good denominators, so it's difficult to get rates. If we have denominator, you can calculate rates, but usually what you get is fractions. That basically is what proportion of deaths in your sample are due to HIV, are due to this, are due to that. Okay, so go to the next. Click, please, next. So this is how it works. So there is a death, and usually someone knows in the family definitely, but in the community, local government, some health professional, community health workers, they know about the death. And the problem is that death stays there. And we don't know anything else. Many times, not even the fact of death is recorded, not talking about causes of death. So then for the verbal autopsy to be implemented, that this death needs to be captured. If you click next. And this is what we call like death notification. And that notification could have many different forms. It could be electronic. In some countries, could be paper-based, could be even, I am now in Laos and in Vientiane. Sometimes in Vientiane, they use even WhatsApp to report deaths, which is not the ideal. But anyway, but someone needs to know there is a death in that village, in that household. If you go next, then once we know, we have like the list of deaths in that district, in that region, in that village, you click next. Then usually the health sector is informed. Say, look, there is a death in your catchment area. Please, you need to do a verbal autopsy. So then usually, depending on the context and on the culture, you wait probably from 2 weeks up 4 or 5 months. 5 months is kind of the limit for recall bias. So if you go, 5-6 months is kind of the maximum to make sure that the family remembers the sign, the symptoms, and everything around the time of death. But someone from the health sector will go to the household, or now we are doing a lot of tele-VA, like telephonic verbal autopsies, that are working quite well. We collect the questionnaire, we collect the narrative, and that's pushed into a central server that then is analyzed. If you go next. And how do we analyze the verbal autopsy? There are two main ways to analyze. We can use humans, or we can use machines. So on the human side, basically it's a doctor like me, or like someone that knows about verbal autopsy. You look at the answers to the question, you read the narrative, and you say, look, the most probable cause of death in this case is A, B, C, and then you can assign an ICD code as well. That's useful, but then doctors, many times we are not very consistent. If you give me one case today and the same case 3 months from now, I may assign a different cause of death. So we are not very consistent in our answers. And also to do it at scale is very difficult. So in Laos now we are collecting 3,000 verbal autopsies. So going through 3,000 verbal autopsies is time consuming, it's expensive, and doctors are usually better looking after people who is still alive. And then on the other side, you have computer-coded VA. That is basically we have mathematical algorithms that will analyze the answers and will produce the most probable cause of death. And I can go a bit into that if there are questions. If you go next. And once you have analyzed, you get this type of table. This table is an example of the cause-specific mortality fractions from one country. And you see HIV with the ICD code, 17%. So 17% of the deaths were due to HIV, according to in this case, is the algorithm InterVA. If you go to the next. So the key components of the verbal autopsy when we are trying to integrate in CRVS, because part of this is not only for statistics purposes, and this is a point that I wanted to make, like death, the fact of death and the cause of death has statistics, but also legal aspects, mainly the fact of death. So in our case, we try as much as we can. Whenever we capture a death through verbal autopsy, we try to link it to the civil registration authority so that that death is registered. And that's essential. So every death should be counted, every death should be registered. And then the cause of death comes after. In this, having digital data collection tools helps a lot. There is a ODK, this is the tool that we usually use, but you can use Kobo tool or other tools to do the questionnaire. Then you need data storage and management so that you can compile your list of deaths and your output of the analysis. And then you need to decide on your cause of death assignment method. If you go to the next. And to take you through this process, at the WHO reference group for verbal autopsy, we have developed plenty of material. So you have basically everything there. So there is the questionnaire in paper, electronic as well. There are interviewer manual, trainer manual, supervisor manual. If you go to the next, you have the ODK guide, you have the XML file for just bringing, like, uploading it to ODK or Kobo tools or any other data collection tool. If you go to the next, you have like tools to see like how can I integrate verbal autopsy processes within my information system, whether it's a routine government system or an NGO system. You have tools to identify the sample size needed for verbal autopsy, identify the cost. You have what we call the OpenVA pipeline. That is like a sort of a pipeline that connects ODK with the analytical tools, with DHIS2 as an output, with other systems. So it's really, and all of this is open source. You can take it, use it. So if you go next, I think, yes. So you have plenty of tools to integrate verbal autopsy. The reference group also can help you in answering questions. But just to summarize, fact of death is important, is super useful, but also cause of death is important. It's important to understand why people die, what is the reason why they are dying, and get to the bottom of what is the underlying cause that triggered the events that ended up with someone dying. Thank you so much.
Thank you so much. Thank you, Professor Les, and thank you so much for your presentation as well, Daniel. So I will go to the questions. This was very, very interesting, and I can see we have lots of questions. I'll start from the bottom, moving up, and maybe select a few. Not that I'm not being biased. I'll just try to select what's been coming in. So there's a question here. What's the best way to estimate community deaths and its chain of transmission to the national database? Community structures may not be able to triangulate the underlying cause of death. I don't know who wants to take this. Maybe Les, would you like to?
So I can't give you one answer because it's so different in different places. And if you are in like northern Mali where the government isn't functional, like the answer is completely different than southern Mali where the government is highly functional. So I can't give you a clean answer. I can just say that if you are interested in quality of medical services and quality of outreach and the messages you should be having to make the health system work, then suddenly, as Daniel just said, cause of death and also finding out, are the deaths that come up to my clinics and are in my system different than those deaths that community health workers are telling me about that are far away and never get there? Making sure they're the same are pretty profound. But I can't, in terms of the chain of communication, it's so case specific. Daniel,
I don't have an answer, but I may have a method because I agree with you. It's very context specific. One thing that in terms of like information flows and how deaths are being compiled, we've been using a lot business process analysis to identify, okay, how these deaths end up in which data sets. Because what we've seen is that we have plenty of data sets, or we have multiple data sets, but they are not connected, they are not aligned. Deaths can be ended up in 2-3 databases at the same time. And doing this process analysis of, okay, what are the information flows within my organization, outside of my organization, how they are connected, how they are disconnected, and then try to, if you have enough data, like trying to understand, okay, who is in which data set, try to match cases. That has been really useful for us in stable settings. I am not certain about humanitarian settings, how feasible is that, but understanding information flows, I think that's really useful.
Thank you so much, Daniel. And I think this is another question maybe for you, Daniel. What are the barriers, limitations to verbal autopsy? And if it has been a standard since the 70s, then why has it not been standardized across contexts?
Mm-hmm. Yeah, so it started in the 70s. The standard has been less time, I must say that. So there is the WHO standard, I think, from 2007, but still the question applies, like why it hasn't taken traction. I think it and I came like probably 12 years ago, so I don't know before, but I had the feeling that it was seen as a research tool and not so much as a tool that could help governments or agencies to understand what are the causes of death in their environment. And then also I do think so, and verbal autopsy has limitations. So it's not that verbal autopsy is useful for everything. So you have verbal autopsy is good at the population level, so it has an accuracy of 70 to 80% at the population level. But then when you go to the individual level, if I want to know the cause of death of that individual patient, then the accuracy is much lower. So at the individual level, verbal autopsy is not that good unless a doctor looks at it. If a doctor looks at it, then it's okay. But with algorithms, it's population level. So that's also a limitation for verbal autopsy. If you have just 100 cases, it's difficult to run the analysis and have your cause-specific mortality fractions accurate for the top 10 causes of death. And then also, like, another limitation is that it takes time to do the VA. So similar to probably some of the surveys, it takes probably 30 minutes, 35 to do the questionnaire with a family that has just lost a family member. It's true that the refusal rate is very, very low. People, I have the feeling that they like to talk about what happened, and they value that someone comes to the household and asks, okay, what happened? What were the symptoms and all of that? But still, to implement a verbal autopsy is not something that you can do with low resources. We are seeing, like, for example, with these new innovations like telephonic verbal autopsy, and now some of the methods to reach to people is it becoming much cheaper, and you need less resources, but still it's a resource intensive activity, I would say, and that's also another limitation to implement it.
Yes, go ahead, Les. You would like to add something?
2 other thoughts, and that is a huge limitation is when you have something like snake bites, where a huge fraction of snake bites result in death, at least in CAR, where I've been working most recently, and like none of them end up in the medical system, you can have really deceptive sort of cause of death descriptions. So that's thought number 1. And thought number 2 is that cause of death is apolitical. And WHO is pushing this for a reason. Like, there are lots and lots of places in the world where this information will allow you to do better outreach, better care, to spend your medical limited budget in a more logical way. And so it has a certain appeal in those many places where measuring a rate would be political and problematic. In Ethiopia a couple of years ago, MSF did a survey a mortality survey that they never released because they were worried the government was going to kick them out of the country. Likewise, in the Central African Republic, MSF was going to, and then they didn't because they realized the Ministry of Health was very, very reluctant to touch this with Wagner soldiers sort of at the key. So mortality can be hyper political. Cause of death data is virtually never political except for violent deaths. Thank you.
Thanks. I think for listening to you, Daniel, also it probably brings to mind that maybe then verbal autopsy might not be the methodology to go with, maybe in an acute humanitarian crisis where, you know, there's still a lot of chaos and people are on the move. And I think this is a question we have here from Mira. And the question is, what's the best way to communicate or measure collateral deaths? So, for example, people dying during an earthquake versus people dying due to like a hospital collapse and not receiving healthcare. So this, I think, is very important to many of us who are humanitarians. So, what would be the best way to measure collateral deaths? Anyone?
Yeah, so
Yeah, go ahead, Daniel.
just a thought. I'm not an expert in this setting, definitely, but I do think that the verbal autopsy questionnaire, I think it can help structure the interviews of doctors when someone is dying. Like, it's very easy to be biased towards a cause of death that you are expecting to see. But the verbal autopsy forces you to go through a structured questionnaire, and we are using that, for example, in Zambia for death on arrival, and it's useful because it forces the doctor to go through a structured set of questions and listen to symptoms. And maybe it's not because of the trauma; he or she died because she didn't have access to the drugs or for her treatment. So it's a different. So it forces doctor, but I don't think like for example, the algorithm analysis would be super helpful in those situations.
Thank you. I also see a question. I don't know if Masood, have you put your question in the chat or in the question and answer? Maybe you have. Just check.
Sarah, I moved some question from Q&A into the chat, if you can see it. Yeah, please.
Thank you. Thank you, Narian. Yes, so the question is, can social network data be used to estimate mortality and causes of death, and how effective is this approach compared with traditional mortality surveillance systems?
So actually, I've struggled with this quite a bit. The answer is it is not helpful at getting rates. It is really, 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 really problematic at getting rates because if you're dealing with like drug abusers or homeless people or refugees who have just arrived, they know each other so well and they're so connected that you will get information about them, but you won't get a denominator-based experience. So yeah, you can't get a rate with these social networks. And there is overwhelming evidence that even calling into key informants or calling into imams gives you really, really, really skewed results. Bronwyn Nicole did this amazing study in North Kivu that showed the average person in a village knows about births and deaths better than the chief of the village. And you know, we think of chiefs as being really informed, but no, they're not informed about that child who died 2 hours after it was born, or and births happening and that kind of stuff. So like, you need a denominator for a mortality rate. If you want to be able to get anecdotal data, if you want to be able to guide reporters to a huge, huge, huge problem, then those social networks are awesome because they can give you insights. Thank you.
Thank you. Thanks very much. There's another question here from Amal. And she's saying, I'm wondering how you mitigate the risk of misclassification of the cause of death, since a child who died with fever and convulsions could have had malaria, meningitis, severe pneumonia, or sepsis. Without laboratory confirmation, differentiation is difficult. So what other sources do you use to ensure that you can conclude the root cause of the mortality? Maybe that's for you, Daniel. Or
yeah, just a quick point. So it's the most probable cause of death. So we know what we know. We cannot know everything. So if we see a family after 3 weeks, and this is what we have. So we need to work with what we have. So that's the upfront. So in the questionnaire, you have different, at least in the verbal questionnaire and the algorithm, you have different questions. And then the algorithms can produce not only the first ranking cause, but they can produce, look, this is the first ranking, this was the second, the third, the fourth. And some people are starting to look into those other causes of death for misclassification, and that could be done. But then if you have the resources and you get to the child in the first 24 hours, there is this method, the minimally invasive autopsy, where you have, it's a method that has been used in stable settings where you basically you have some micro autopsy and micro punches of different organs, and then you analyze that. And with that, you have much more accurate, primarily for infectious disease diagnosis or under cause of death. But still, it's very, to me, it's a bit unrealistic that you can get in 24 hours to a kid that has just died and do these punches even in a stable setting. So that's maybe useful for kids that died, children who died in a hospital or in a health facility, and then you have the kit for the meats there, and then you can do it. But it's a bit tricky. But we need to work with what we have.
Yeah, thank you. Thanks very much. I think I'll ask the last question, which I think is a big one for me as well, for many of us who are not experts in mortality measurement, but who are out in the field and really want to do this work. So how do we overcome academic gatekeeping around mortality surveillance? Like, we need to be encouraging data collection and measurement of it, not discouraging it, but sometimes having very rigorous methodologies really discourages people in the field. Or the idea that if I was to follow a certain methodology and bring the results, there might be more questions on what has been done rather than using the data. So over to both of you. This will be our last question. Thank you.
You can go. Well, you can go. I've been first many times.
Okay. My answer would be your need for precision, your need for transcending the academic critics is a function of what your goals are. And if your goal is to get trends over time, like we saw in the Republic of Congo, that when they don't have drugs, people don't come to the clinics, you have really, really low standards for what you need. If you're trying to declare famine, you need to have really high standards, and thus there are so many people like Francesco Cecchi at the London School of Hygiene and others who just love coaching people out there on the front and will help them sort of figure out, if it's a surveillance project, how can we take an independent grab and determine how complete the surveillance is? Or if it's a survey, to sort of review the protocol before they start and make sure that they're thinking about all the lingual complications of what a stillbirth is versus a neonatal death versus a live birth. And there are so many people who have gone through this before, and the whole purpose of this meeting, the whole purpose of this initiative is to get those people together. I'll stop there. Thank you for having me.
Thanks, Les. Daniel, would you like to say something?
Yeah, I would just advocate not to not to be fearless in using these tools. At least in the VARC, we are trying to produce as many guidelines and documents so that people can use it. But the best way to learn is to use them. So go ahead, use them. What we don't want is to mislead decisions. But as far as you are clear with your assumptions, you are clear about the outcome that you are trying to reach, and you are transparent with what you have done, then the fact that more questions come, I think, is not a negative thing. So there will be discussion. Okay, you don't agree with this. Okay, let's do a better study. Let's put more data into it. But we need to start generating data and using the data, because part of the problem, just to finish with this, part of the problem is that we are generating lots of data that is not being used. It's not being used by governments. It's not being used by anyone to make decisions. So we need to be fast in doing these things.
Thank you so much. Yes, Les.
I just want to say the first survey ever measuring mortality in a crisis was in Biafra. It was done by this guy who just didn't know what he was doing, ran around, did a survey. In the end, it could never be published because they didn't know how many of the people had fled the country versus how many people had died, but he knew half the population of Biafra was gone. in the end, it made so much influence on Western spending, even though it was academic garbage. So that fearless comment of Daniel's, I love it. Thank you.
Thank you very much. I think we have come to the end. So just in conclusion, I think it's very important to understand that what we do understand is that, you know, both surveillance and surveys, there are many methodologies out there. There is a lot that can be done. Each one has its limitations and has its positives as well. So understanding the context, understanding the community, and having a goal and a purpose, but really trying to get to collecting data that is useful for programmatic action, I think is really, really critical and important, especially in our humanitarian settings. Thank you all so much for attending today. We are excited for learning more. We're also excited in moving this initiative forward. And like Les and Daniel said, to be fearless in the field and collect more mortality data and use it for programmatic action. Thank you very much.